Welcome to Cancer Explained with Dr. Seth Blacksburg, where we break down complex medical topics to make them clear, approachable, and empowering, especially for listeners without a medical background. I'm Seth Blacksburg. I'm a radiation oncologist and an adjunct professor at NYU Long Island Grossman School of Medicine and the chief medical officer of Accuray. Today's guest is Dr. Eduardo Lovo, a neurosurgeon, a radiosurgery pioneer, and one of the most innovative thinkers in the field of non-invasive brain treatment. Dr. Lovo is the director of the ISRS certified Gamma Knife program at the International Cancer Center, founder of the Robotic Radiosurgery Center in Costa Rica, and founder of the International Cancer Center in El Salvador. He trained in Mexico and Chile, completed advanced neuro-oncology training at MD Anderson, and has helped introduce radiosurgery across Central America, dramatically expanding access to advanced brain care. Beyond oncology or cancer care, Dr. Lovo is internationally recognized for his work in what's called functional radiosurgery, which is what we'll talk about, using focused radiation to treat conditions like severe pain and neurological disorders, often when other options have failed. He's also a professor of radiosurgery in Europe. Dr. Lovo is not only a remarkable physician, but he's also a teacher and a colleague that I've learned a great deal from. Dr. Lovo, thank you so much for joining us today.
Thank you, Seth, for this wonderful opportunity to be able to expand the knowledge well beyond our field, our medical field, and hopefully into patients of what's happening in the radiosurgical world.
Speaking with you is always exciting for me. And before we get into the content, one of the things that I thought would be fun, and we did this even before shooting, was just to get to know you a little bit better, and especially for audience. I always find neurosurgeons fascinating who find their way into radiosurgery. You trained as a neurosurgeon, so it's clearly, for folks outside of medicine, neurosurgery is one of the most, if not the most, technically demanding fields in medicine. And then after training, you became deeply involved in radiosurgery. Talking about yourself, what drew you to medicine and then specifically neurosurgery?
Yeah, actually I'm writing a book. That's how deep it is, Seth. But the important thing is that, I had to go back all the way down to infancy to understand what we're doing now. Now what we're trying to do, Seth, and I'm not trying to avoid the question, is we're trying to understand what's next. What goes beyond what we can do right now in the neurosurgical field. Like, if I can remove a tumor, that's okay, because that's what we were trained for. But we haven't been trained to restore function, something that was damaged by that tumor. So that has me right now in an adventure to understand what's next. And the field of radiosurgery, of course, is experiencing some advances that may be part of that next future, that future that we are all looking into now with AI and robotics and so on and so on. But going back all the way back to infancy, I was born in a war-torn country. That's where it all began. I was in El Salvador in the 80s. I was born in 75, but in the 80s, I became more or less conscious of what was happening, in the morning and in the daytime, I was very happy playing outside in the street, playing in a tree in front of my house. But at nighttime, it got scary because we would hear the bullets and explosions outside. So for a 5-year-old to understand what was happening, you only understood there was danger out there. But moving on forward from there, and I got interested in medicine, I actually went to the Army, so I am a military doctor. The interesting thing about that was that I was trained on dogs in the military, because all Army doctors needed to be trained on trauma surgery, right? And for some reason, my mind as a child that created this structure of protection that was not real, but it created the structure of protection from bullets and from bombs. In my medical training, it created the structure of protection of feelings, of surgery, of feelings in surgery. And we started to seeing the biological no difference between a human and a dog. So I was technically good. I don't say that, just because for any reasons, but I was technically good, but I didn't have a heart because my mind protected me from this violence or structured violence that goes into surgery. And then I went into Chile to study neurosurgery, and that's where it all changed because I was forced to go into internal medicine and talk to patients, something that I had never done, and talk to their families. And then my mind started morphing radically, and it changed forever. It changed forever in a way that now I understand that the less surgery you do might be the best option for the patient. Non-invasive treatments such as radiosurgery just make sense. You know, surgery sometimes in my field is about ego, but ego needs to be overcome by compassion over patients. And that has been, you know, a major debate in neurosurgery regarding radiosurgery and neurosurgery for as long as I remember. It was, oh no, we can go into the cavernous sinus and look how I peel it, and this is the carotid, and it's perfectly exposed, and whatever, whatever. But the patient can be injured by surgery. So radiosurgery made sense to me. I saw it for the first time, and then it became a passion.
What a beautiful story. And I don't know if I'm misquoting the words you use, but your sort of personal transformation into the role of, you know, from a technical wizard to a healer, the full spectrum of healer. How did you word surgery? Very structured violence or a controlled violence?
It is, you know, in all forms, surgery is a structured violence. It's you're violating the body of your patient because you are creating incisions, you are rupturing tissue. When we talk in Spanish and you say "Oh, we submitted the patient, we subdued the patient," you're basically saying that you're forcing the patient into a position, and then you're creating incisions and cutting through bone and doing whatever we're trained to do. So if you understand that, that is a necessary violence that we execute on another human being. And of course, that is what we hope traduces into a great outcome. But that's what it is. So, in a way, when you think about in less invasive surgeries or no surgery at all, then you become every time less violent with the patient. So if you can get the same result without amounts of violence, then you definitely have a best procedure. If you can get it with a pill, even instead of radiosurgery, or if you can get it with a vaccine or a shot, that is even less violent than even radiosurgery, which is a non-invasive treatment in the brain or somewhere else in the body. Those things populate my mind all the time, and we try to move forward here in El Salvador in Central America and try to advance into what will be the future, Seth. You know that the future now is changing extremely fast. It's changing extremely fast. What we know in medicine now except with the basis, right? Because the human body still works the same way. It hasn't changed because AI came along. but the medical advances will transform everything we know. It will transform cancer itself. We need to get into that, even as surgeons.
Functional radiosurgery soon, but you know, it's so poetic the way that you word it, and obviously downstream from the word violence is trauma to the body. And what was your initial exposure to radiosurgery? When was the first time that you saw it, heard about it? And can you just talk about just the beginning of your experience with it? And maybe just for folks who are hearing this word for the first time, because radiosurgery is not part, I don't think, for anybody outside of medicine. It's not, nobody uses that word. Can you just describe what it is and how it's different? You know, you have different tools in your hands. You could do incisions, you could do radiosurgery. If you could talk about maybe just your first experience with it, and then just what is it?
Yeah, because we immediately jumped into radiosurgery without explaining the concept. So in a way, the part of radio, which has to do with radiation, in a way, you go to a clinic and have an X-ray done with you. That's radiation. So we use energy, radiation in this case, to focus an area, and we'll talk about the brain, but you can do this outside the body, and that's the beauty of CyberKnife, right? But if we're talking about the brain, what we do is we focus this radiation into a point in your brain, either a tumor or arterial venous malformation or a nerve that is hurting, such as the trigeminal nerve. So the more we have this focused energy, this more radiation accumulates, the clinical outcome of what we're seeking. So in a way, it's a non-invasive form of administrating highly focused radiation to a space in the brain using submillimetrical accuracy. So all those words mean we're very accurate on what we do, and we do introduce to an area of your brain a lot of energy through forms of radiation. I don't know if you have a better explanation to that, Seth, and it's called surgery, radiosurgery, because a neurosurgeon invented it. So that's where the term radiosurgery comes from neurosurgery, and the machine that he made is called a gamma knife, like if it was a knife, but it has no knives in it. It makes no incisions. So this comes from the surgical world, but it has nothing to do with surgery. It is the complete opposite of surgery.
One of the pleasures of doing the podcast is listening to experts like you convey these complex topics in, easily digestible ways. And it reminds me of the first time I heard of radiosurgery. It was 2002. My brother-in-law's mother had a meningioma, as you know, a non-cancerous lesion, and she was treated with radiosurgery, and she came back and there were no incisions on her head. And I didn't know, I was in medical school. I didn't know anything about this. And it sounded like science fiction. I remember distinctly thinking of something out of like Star Wars or Star Trek. And even as you're describing it in these, very simplified ways, I can't help but sort of get transported back to that point in my life, listening to something that is so effective. It provides so much good for people. And yet, even after all these years, there is something that brings me back to, it's almost a science fiction type of feeling that you can harness this type of energy. You could direct it with a precision of less than a strand of hair, and that you could treat areas deep into the body without ever cutting in the skin. It's amazing what you and others have been able to do and take care of folks this way. It's pretty remarkable.
Yeah, no, absolutely. That's in a way, if you try to explain that to a patient, even if we've done this 1,000 times, and even it doesn't matter their level of education, at the end, they're like, so does that really take place? That sounds like magic. And sometimes I joke with them and say, yeah, it's magic. It's all magic, because it is a different concept. They come to me most of the time worried that they need open surgery, and they imagine open surgery as anyone who's not a neurosurgeon doesn't want to get their skull opened or, or their brain touched. I wouldn't. But in a way, when you give them the option of radiosurgery as opposed to surgery, it sounds like something magical, like something magical. And it technologically, it is. It is. It's a concept that has evolved over decades, but it is in a way that we get less invasive into patients, in a way of how a radiosurgery suite looks like in comparison to an OR suite. That's the magic, and that's the beauty behind radiosurgery.
I think one of the things I truly admire about the different folks who can wield this tool of radiation are radiation oncologists and neurosurgeons. Amongst others, one of the things I truly admire about neurosurgeons like you is the fact that you have every tool in your arsenal. As a radiation oncologist, I believe in radiation. It is my tool. I don't have another tool. I would just call my friend. I would say, well, you should see Dr. Lovo. He has another tool. You have both tools. When you see a patient and you're talking about radiosurgery, how do you counsel them on what they should expect? Are they going to feel pain? Are they going home? Are they staying in a hospital? How do you make a decision on which of these tools you would use? And then if you do choose radiosurgery, what should be the patient's experience through it?
Yeah, of course. Remember, Seth, and I have to remember your audience, I practice in El Salvador. So practice varies worldwide. You're in the US. It varies from Latin America to Europe, to US, China, wherever you are. So it varies widely. This is the most important thing, that practice varies widely. It varies according to economical capacities of the patient. The choice has to be made in conjunction with the family members, the patients. What do they think? There are certain cultures where opening the body is still looked in religious ways. So radiosurgery is more prone in those areas of the world. Then you have sometimes the fortune to have a honest conversation, putting both surgery and radiosurgery for the patient to choose. And sometimes you only have one because economical factors or whatever factor, and you have to choose the most efficient one. And obviously you're not doing the choosing. You have to be of a advisor. You're here to advise the patients what is best for them. And you let them know exactly how it works in surgery and how it works in radiosurgery. I know I've talked about a violence in surgery, but most of neurosurgeons are actually very good surgeons, and the surgeries in the brain do outstandingly well. But you have to tell them the truth. How are your results? How are your complications? And then you have to talk the truth about radiosurgery. And somewhere in between, you have to have brutal honesty so the patient can make their decision and finally choose which way they go.
What's the most common type of brain lesion for the average person who's thinking of radiosurgery? What's most commonly treated with that type of technique?
That was your aunt got treated by that as
That's right.
meningiomas
That's
by
right.
far. So for the non-doctors out there, meningiomas are benign tumors that grow inside your skull. They're not inside the brain, so they will displace the brain or nerves or not, or just be there. Right? They're more common in women. We think that that has obviously a hormonal reason, but that's the most common benign tumor that we see. Treatment has morphed dramatically from when I was training in neurosurgery. It was, oh, you got to remove that, and you got to take out the bone, and you got to take out everything out, because then you cure the patient. And it resulted that you didn't need to do that. You need to sometimes just remove enough so the symptoms of the patient improves. And once you've done that, surgery is done. That patient will go to radiosurgery. So you can control that tumor without any risks for the patient. Most of my surgeries, I will say 99% of are considered outpatients. So that's surgery. We're not talking about radiosurgery for brain tumors. So it's 1 day of hospital stay and they go home. But the important thing about that is that if you compare that to radiosurgery can be minutes. So once you've done your CTs and your MRI scans, so we have the maps, so we can produce these beautiful plans of your treatment. You go inside the machine, either CyberKnife or Gamma Knife or whatever machine you're going to receive radiosurgery with, and treatments can be as little as 5, 10, 15 minutes, or they can be a little bit longer, anywhere from 35 to 45 minutes or an hour. But the important thing is once that's done, they go home. They go home, or they go shopping, or they go have lunch or whatever. And that's the big difference from having your brain operated on and having your brain receiving radiosurgery.
So benign brain tumors are the most common, or amongst the
Yes.
most common. Do you also treat non-benign brain tumors?
Yeah, great question. And I tell you this, as I started mentioning, practice varies depending where you are. If you are in the US and most countries in Europe, the most common tumor is not benign tumors. It's malignant tumors, they're called brain metastases. So what the term implies is that you got cancer in another part of your body, say your breast or your lung or whatever, and it went into the bloodstream, and then it got impacted in your brain, and it creates a seed there. Well, it create a malignant tumor called brain metastasis. And this is the most common if you're in the US. But when you look at the Latin American numbers, and there's a reason for that, and it's economical as well, it's not brain metastasis the most common that we treat. It is benign tumors. But again, that's just where you're practicing. You have to be aware that you're going to be treating different diseases.
Mm. I remember, so I was introduced to radiosurgery as a radiation oncologist through the cancer pathway first. And what we used to do on every patient is once they had these malignant tumors in the brain, the guidelines at that time, at least in the US, was if you had 3 or more that you can see, the likelihood is that you have so many more. And so what we used to do, and it's not that long ago, but we would do what's called whole brain radiation. We would basically have one beam go here, one beam go here, and we would treat the entire brain with low dose radiation. And we thought we were doing the right thing because the guidelines said that's the right thing. And there was benefit in that you would prevent, there was a high likelihood that you could minimize the chance of these other tumors popping up. But the problem was there was all of this collateral damage because we were aiming at the entire contents of the head, all of the brain. And more over the past 20 years, we're seeing for the malignant cases, that guideline of like 3 or more and treat whole brain, it's actually flipped the entire opposite way. As the world has embraced radiosurgery, it's now all about quality of life and minimizing damage to healthy tissues and doing a course of radiosurgery. And then you could always do another course and you could do another course. And do you experience that ever with benign or malignant where you do repeat courses of radiosurgery?
Yeah, you touched upon one of the most dramatic stories as a neurosurgeon that I have lived through for the past 18 years. You described your reality, right? You described the US reality. But from the Rio Grande on down, whole brain radiotherapy is the leading treatment for brain metastasis. And it is worldwide. It's not radiosurgery. It is whole brain radiation therapy. It is certainly here in my country where we have a dedicated Gamma Knife. It is certainly in Costa Rica where there is a CyberKnife system because there is no access. So if you're in Honduras, Guatemala, or there's no radiosurgery capacity, you're going to get whole brain. Believe me, you're going to get a whole brain. So we already know what happens if you give whole brain. We know it creates cognitive decline, but it's better than not giving any form of treatment. And that's the important thing, is to understand that societies work with different realities. The brain metastasis scenario was something that led me actually took me to MD Anderson later because I was fascinated by brain metastasis. Actually, the first article that I wrote back in Chile was about surgery for brain metastasis and its survival. So this was back in 2004. So a long time has passed. But I was fascinated by brain metastasis, and I still am. But then you come to this reality and you see that people are not getting adequate treatments. They're not getting adequate access to technology. They're not getting adequate doctors, physicians, experience to treat brain metastasis as we should be treating them. This was so much the case that we created about a year and a half ago a program called Gamma Knife Guaranteed. So in a way, Gamma Knife is another technology for giving radiosurgery, but this would be in a more understandable framework, radiosurgery guaranteed here in El Salvador. So what does it mean? If you get treated once in our institution, all the rest of the treatments are free, because the biggest challenge that we had was not treating a patient with brain metastasis. It was treating him again or her again at 3 months and say, oh, another one popped out. So what do we do now? Oh, now you have to pay again. But I don't have any money. Also, there's nothing we can do. So, these are the bare realities that we face here in El Salvador and worldwide, by the way. So, brain metastasis has a very deep place in my heart and my mind, because the good news is, there's a good news for this in El Salvador, is that we began treating brain metastasis, of course, a long time ago, about 11 years ago or 12 maybe, with radiosurgery. But then recently, one of the national centers acquired a LINAC, which is a machine for giving radiation, which is very advanced and has radiosurgical capacity. So it's the first LINAC with radiosurgery capacity to treat brain metastasis for everyone. So access now has been liberated, and hopefully it'll become universal in El Salvador.
Your experience, it must be amazing for you because you've trained in different countries, you lecture in different countries, you travel to different countries, and you're also a pioneer in radiosurgery. So I think the point you're making, which is so interesting to me, is that you really, in these different countries that you either operate, lecture in, provide support, or counseling for, you really do see that full spectrum along the radiation to radiosurgery, traditional surgery. You really see that full spectrum of treatments, and that must be fascinating for you. I don't know if I'm using the right adjective. It must be very interesting to see in every country that you're at and different regions of different countries, wherever they are in the journey towards advancing radiation.
Yeah, and I think that it's not advancing fast enough. Obviously, whoever is on this side, as you are, Seth, of course, we always think that it's not fast enough.
Right.
We always wish that it would be faster. But I do see a trend in Latin America to more and more acquire technology and capacity to be able to treat the whole population, not limiting by economical resources. That's the key. I mean, if you're not naive about it, the world is designed that way. If you have more access because you have more economical power, and there's people that have less economical power and have less access. So the question is, how do we help in trying to level that playing field, right? How can we do that? And either is through pulling or pushing through leadership is what we need to do. Either you push the national system into purchasing radiosurgery equipment, or you pull them. You don't necessarily push them, but you say, okay, so we're going to do it. And then people get upset and say, oh, why do I have to go there? I want to go here. And then hopefully that gets the ball rolling, and then they purchase enough systems so the country is covered, and we improve.
And the beautiful thing about it, whether it's blended or it's a push or a pull, is what the data shows pretty compellingly. And even as you articulated, is radiosurgery is quite cost effective, compared to somebody having incisions and being out, or sometimes even drugs that will cost so much money. There's so much compelling data that radiosurgery in general tends to be quite cost effective.
Absolutely. It's something that in another podcast I explained. It's what does a radiosurgery machine does for me? It multiplies me by 5, at least, if not 10, right? So I do, say, 20 radiosurgeries a month and 15 craniotomies. So that's 35. But if I would have had to done 35 surgeries, I'll probably be dead by now because, there's so much pressure that comes from surgery and so much OR time. And that's much more expensive. That has much more cost than radiosurgery. So, of course, it's more cost effective than surgery.
I want to go into a topic, and I don't know if you'll remember this story, but it left a mark on me and it's what I think of when I think of you. So I want to give a quick background. I want to talk about the future of radiosurgery for a moment. And you are on the cutting edge, no pun intended, on that. In 2011, 2012, I remember I was working in a hospital and I was working with a certain type of radiation equipment. I was doing radiosurgery for patients, And somebody came to me, a neurosurgeon, and said, I want you to treat the nerve, the trigeminal nerve of a patient. They're having a lot of facial pain. And I heard of this trigeminal neuralgia, this pain in one of the cranial nerves. I did my research on the machine I had, and I said to the neurosurgeon, no, thank you. I don't want to do it. And they referred to me some literature where somebody was using the machine I had in Germany. And they said, well, you should do it or consider it. And it felt to me, the precision that was needed felt to me outside of the range of my comfort zone. And so I did what I thought was ethical. I referred the patient to another center that had what's called a cyberknife, the machine that I ended up using in 2014. And so in 2014, I got to start using the cyberknife machine, which has sub-millimeter precision. And I was started getting very comfortable treating and pretty much anything and treating nerves. So fast forward, that was 2014 where I started treating trigeminal neuralgia, very comfortable. Because again, I had neurosurgery colleagues who would guide me and so I now had a machine I felt comfortable with. I want to fast forward. I joined the company that made the cyberknife, Accuray, and I joined as a chief medical officer. And somebody along the lines at one point said, well, people are starting to explore a concept called functional radiosurgery, where they're directing much larger doses of radiation in different areas of the brain for tremor, for other movement disorders, for a whole range of disorders. And my first reaction, it goes back to science fiction. I remember thinking, no, I don't think that's true, or that's in concept. And I spoke about it to other experts who said, no, people are looking into it. I forgot who it was, but somebody along the line said, you have to speak to Professor Eduardo Lovo because you're thinking still, Seth, as a radiation oncologist. You're a cancer doctor. You're not seeing what other people are starting to look at. And so you were so kind to me. This is 3 years ago. We did a call like this, and you couldn't have been kinder to me. You took me through just an overview, and I remember looking at you thinking, like, I don't even, you were talking about giving really high doses. And again, as a radiation oncologist, I always get a little bit uncomfortable delivering very high doses to people without cancer or without a meningioma, without a real big, solid target of abnormal tissue that I can see. And you exposed me to this concept and exposed me to a community of thought leaders like you. And if anybody goes on your LinkedIn page or looks you up on social media, you give lectures on this and you do this sort of thing. But it was humbling for me and it was more exciting than even humbling. But you are my introduction. I just wanted to let you
Oh,
know.
oh, wow. I
Since
didn't know
then,
that.
you were the guy, and you and I had dinner last year at the Radiosurgery Society. We were with, across the spectrum using different machines, thought leaders, but you were my personal introduction to that, and I'll never forget
Oh,
that moment.
yeah.
Can
That's nice to
you?
know, Seth.
It's true. It's true, and I'm grateful to it. And you always remember your seminal moments, your formative moments when you think differently. I know the technology's there, and I remember this is
Yeah,
3 years ago. You telling me you've got a platform that could do this. I'm using your platform to do this.
absolutely. Yeah, cyberknife. Cyberknife is such an incredible machine. If you think about it, since it came out, it was revolutionary by design. It still is, because there are other machines out there, but none have the design of a cyberknife. But going back into the functional, Seth, and to put into context who those people that are hearing us, if you treat a benign tumor with 12 gray, which is the energy, the name of the energy that we use to describe the energy that we use in radiation. Then obviously radiosurgery, functional disease, we're talking 10 times that. We're talking about 120, 140 gray. So yeah, it's a lot more energy delivered to a focal point in the brain. Absolutely.
So anybody listening to this, you could imagine your doctor giving you aspirin, 81 milligrams, and then there's another doctor saying, well, if you take 10 of those, I can
Yeah.
treat something else. The
Yeah.
first time you mentioned these doses to me, right, we're talking about an order of magnitude different,
Yeah.
and you're now aiming at normal brain, not an abnormal conglomeration of cells. Can you do for the audience who are non-medical people what you did for me 3 years ago? Can you just introduce the world in some ways to what functional radiosurgery is and where are we even as a field? There are people like you. Even in my travels, now I've traveled across the world. I'm in, this role. There aren't that many. There's still a very specialized group. Can you sort of just bring us up to sort of what is functional radiosurgery? What type of things are you treating? And then where are we in sort of the evolution of this?
Yeah, absolutely. And again, as the term radiosurgery doesn't make much sense, the term functional radiosurgery doesn't make much sense either. What does functional even mean? Is it functional disease or functional well-being or whatever? But functional, what it means to neurosurgeons, it's a subspecialty of neurosurgery, and it's called functional neurosurgery. In functional, what you do is you treat what you would call all those diseases that are not marked by tumors or by arteriovenous malformations. And these include pain, which is a very important part of functional neurosurgery, where you have no other alternative than to try to modify the mainframe where the information goes, which is an area of your brain called the thalamus. So you try to modify that by whichever means, radiation, ultrasound, or electricity, or whatever. And then, but you can treat a large spectrum of diseases, such as tremor in Parkinson's disease, which is a very hot topic there, essential tremor, which is a very debilitating disease or can become very debilitating, especially in the elderly patients where you're shaking and you can't even feed yourself. But there's also the more abstract areas in functional disease, which is epilepsy, and of course, psychiatric disorders such as depression, anxiety, obsessive compulsive disorders, and so on and so on. So basically, functional neurosurgery, functional radiosurgery is treating that pathology, that for some reason we cannot further treat with medicine, and now we're treating with radiation therapy.
How many of these types of treatments are people doing? Have you treated all of these different conditions? Are there some that are
Yeah.
easier to treat than others?
I've treated all. I've treated everything. No, I've actually have. I think most of what's been described, I've done in functional radiosurgery. I've done it. But the interesting thing is that when you see the amount of people in pain, for example, in the world, so it's 20% of the population with chronic pain. Okay, that's a humongous number. That dwarfs cancer so much, because cancer is 0.4% of the population. So just pain alone, and if you say, no, but 20 is too much, okay, just put a 2%. That'd still be 4 times what cancer is, just pain alone. And then we haven't gone yet into epilepsy. We haven't gone into addictions. We haven't gone into depression, OCD, anxiety, and so on and so on. So the numbers of patients with functional diseases, according to neurologists and neurosurgeons, are millions, much more than cancer.
When you ablate with functional radiosurgery, whether it's somebody with intractable, uncontrollable pain or a movement disorder, and I like the way that you word the thalamus as the mainframe, how big of an area are you treating? Is it an area that's like the width of my finger? Is it a millimeter? Like what's the typical size?
That's a wonderful question, but we have to rephrase it because, and we have to do an explanation. Ablation means destruction in medical terms. When you ablate something, it's you make it disappear. And that you can obviously do with radiation. If you give enough dose, you'll ablate something. But the current trend, at least in my mind, is not ablation. Remember, we have to be less violent, Seth. So,
That's right.
so it goes back to when we start. We
I
have
knew
to
you were
be,
starting with it.
we have to be less violent. So now the term is, at least in my mind, is radiomodulation. So, which means basically that you're giving a much lower dose. So you're not trying to destroy a tissue in the brain. You have to destroy when you have to destroy. For example, you're going for tremor, and we know that you have to destroy a target. Then you give enough dose, and that's standard. But if you're going for a tract for that target, say in tremor, you might not need to ablate it because we're becoming more precise. We're understanding the connections between that mainframe and the rest of the brain. So if we understand the connection, maybe we don't have to destroy. Maybe we just have to give enough energy to modulate. To modulate means basically to alter the electric activity at that level, and you don't necessarily have to destroy it. And going back to your question of size, so typically you would be doing this with a 4 or 5 millimeter radius. So it's a very tiny area that is receiving a high dose of energy. But if you look at the low energy, it is much bigger. It's about 1.5 centimeters. So it depends what you're trying to do. Are you trying to modulate an area, or do you have the necessity to ablate it, to destroy it? But that's the beauty of radiation, because you can do both, which you cannot do with another technology that uses sound waves. Either you destroy with sound waves, but you don't modulate, because the modulation doesn't last enough. But radiation, it does.
Radiation oncologists think about modulation as it refers to shaping things. And you use modulation in terms of how you escalate and de-escalate and sort of create gradients of dose. And I have to say, one of the most fun aspects for me as a radiation oncologist is expanding my mind and thinking differently and learning from those who are using these tools in novel ways. And I have to say, on a very personal level, it's very exciting speaking with you, and it's inspiring.
Thank you.
So.
And for the term modulation, I always thought it in a different way. For the people my age, if the, people don't use radios anymore, but you used to turn the dials, right? And you would go through an area of noise. So that's the way I think about it. That's what's happening in the brain. It's going through an area of noise. So the idea is to turn the dial enough so you can hear the nice sound of music, and you order how the neurons are firing, and they're not firing chaotically anymore. They're firing in a nice way. So you don't have to do destruction for that. You just have to modulate like we used to modulate old radios and to put them to hear nice musics.
That's probably a great ending note for this session and this podcast session, because I think in many ways that's probably what we set out to do with this conversation, to take something that could be confusing and difficult to grasp and to sort of just tune it right. And hopefully for folks who are listening, you're getting a lot out of this. And Dr. Lovo, thank you so much for sharing your experience, your time, your expertise and vision with us. And certainly hoping that we'll have you back on the podcast and find other topics to speak with folks about.
Thank you, Seth. My pleasure. And thank you for this opportunity to speak about my passion.
Yeah. Well, thank you so much. And for folks listening, today we explored what radiosurgery is with one of the world pioneers, and you could look Dr. Lovo up on social media and you'll learn a lot. And again, I'm learning about platforms that I use from him and just overall ways of thinking. If this episode was helpful, please consider sharing it with someone who you think might need it. I'm Dr. Seth Blacksburg. This has been Cancer Explained. And until next time, please stay informed and take care. Thank you so much for joining us.